Today we're going to talk about the heart. And of course, that sounds like a real simple topic. And you can make the heart very complicated, or you can do what I call the box heart. And so what we do is just draw a box and label this RA and RV and LA and LV. And remember, of course, R is right, L is left. So an A equals a atrium, which is a collector, and a V equals a ventricle, which is a pumper. So again, when you're thinking about circulation, you said it has to have a pump. This is the pump. So we can start anywhere in the heart, but let's start out in the left ventricle. So let's start out right here, and let's say that that little circle here, number 1, is a red blood cell. And if it's in the left ventricle, we know that it must be oxygenated. So it really contains, that red blood cell's so it's increased O2 blood or arterial blood in that red blood cell. Now that red blood cell's in that left ventricle, and it's got to somehow get out of that left ventricle. In order to get out of that left ventricle, I'm going to put a valve over here. And I'm going to call that valve number 2. So I've gone from the red blood cell that's in the left ventricle. To leave the left ventricle, I've got to pass through a valve. And so that's going to be number 2. And number 2, since on the left side, that's going to be called the aortic valve, or the aortic semilunar valve, or it could be called a tricuspid valve. And if you think what that's doing, of course, that's going to pump blood out naturally to the systemic circuit and perfuse my body with oxygen and pick up the CO2 as a waste gas. So therefore, the tricuspid valve is going to have a function to prevent backflow from the aorta into the left ventricle. So therefore, since 2 is the aortic semilunar valve, this structure coming out of 2 right here is number 3. And of course, that's the aorta. And we've already talked how that aorta bifurcates or splits into 4 and 5. So there's 4, and there's 5. And of course, 4 is going to be the AA, or the ascending aorta, and 5 is going to be the DA, or descending aorta. So no matter which one we're looking at, we know that since we're looking at the heart, we're going to have to now take that blood and send it to the body. So that blood now is going to the body or systemic circuit of the body. We're going to undergo external, remember external respiration over here, so we're going to undergo internal respiration, which means we're going to perfuse body cells with oxygen. When we perfuse them with oxygen, we're going to take that blood and carry that blood with the CO2 back to the heart. So when I perfuse the body, I've got to take that blood and send it back to the heart. So that's got to go all the way back into the right atrium. So now I've taken this blood, the A and DA, I know that it went into the systemic circuit, also went into the coronary circuit, you remember, because a branch we just talked about of the coronary, of the ascending aorta is going to go into the coronary circuit, but I've got to reperfuse that blood with oxygen. So now it's going to enter, that blood is going to have to enter the right atrium, except remember the coronary circuit, if we were to review circulation, we have to realize that in the coronary circuit, there was that exception to the rule where 80%, and I'll just put it in there, remember 80% of that blood in the coronary circuit went to the coronary sinus, and 20% went back into the small cardiac veins. But no matter what they are, they're still returning to the right side of the heart. Now I'm in the right atrium. The right atrium is the collector. Can't do anything but collect blood, but now it's got to pass through a valve. So here's that same red blood cell. It now has to pass through a second valve. The first valve it passed through, remember, was the aortic valve. Perfuse the body with oxygen, perfuse the heart with oxygen, return that blood back into the heart. There was just that one exception to the rule of the small cardiac veins of the right ventricle, but that blood now has got to pass through this number here, and so that is number 6. So this is number 6 is the right atrium, so that's 6. And now once I'm in the right atrium, I'm going to go into 7. And 7 is now the valve between the right atrium and the right ventricle, which is called the RAV, or the right atrioventricular valve, which is also called, quote, the tricuspid valve. Now I'm in the right ventricle, but I've got to know the function of that tricuspid valve, and therefore that's going to be to prevent backflow from the RV to the RA during RV systole. When I'm sending blood into that right ventricle to get pumped out to the lungs, I don't want that to backflow into the right atrium, because remember, my heart is beating pretty quickly, and because it's beating quickly, I'm going to end up with too much back pressure. So just remember, the function here is going to be to prevent this blood from, I want that blood to go out instead of going up. So coming out of the right ventricle now is going to have to be another valve. So now I'm inside of the right ventricle, and once I get in the right ventricle, I got to pass through that's number 8, I believe. And number 8 now is going to be the valve between the right ventricle, and of course this here is really going to be the pulmonary trunk sitting out here. So therefore, number 8 is the valve that's called the pulmonic valve, also called a tricuspid valve, or the PSL, the pulmonary semilunar valve. And of course, what that's going to do is that's going to have a function, because remember, I'm pumping now out to this blood into the lungs, so it's going to prevent backflow. From the pulmonary trunk, and I'm just going to put in here arteries, because that's actually what it's going into the right ventricle during right ventricular diastole. So this valve up here, again, you want to think about how this is working. So this valve up here, going back to this tricuspid, that prevented backflow into the left ventricle. And again, this tricuspid over here, the semilunar, was also during the diastole. So this has a diastolic function and this has a diastolic function. So I just want to clear that up for you so you don't get confused with it. And I'll run through this very quickly once I finish it. So now we've got this blood that is in the valve here. So now it's gone through the pulmonic valve. It went into number 9, which is the pulmonary trunk. So that we can put here is actually the pulmonary trunk. And then the pulmonary trunk now has got to send that to the lungs. So this blood here is going to go to the lungs. And then the lungs, of course, that's where I'm going to go external respiration. External respiration, remember, is going to be the gas exchange between alveoli and alveolar capillaries. It's perfusing red blood cells with oxygen. It's carrying away the carbon dioxide to get reperfused. Now the question is, where does it go? If you think about the lungs, remember each lung has got one pulmonary artery and 2 pulmonary veins. Remember, the pulmonary artery is going to have venous blood. The pulmonary veins are going to have arterial blood. So therefore, that pulmonary artery that came out of the pulmonary trunk, one to the right lung and one to the left lung, is going to have to go back into the heart. And so coming out of here, the lungs are going to be 4 openings into the left atrium. And those 4 openings are going to be number 10. And number 10 is going to be the 4 pulmonary veins. But remember, the pulmonary veins are transposed vessels, so they're veins that have arterial blood. Now I'm inside of the left atrium. I've got to get out of the left atrium because I know I've got to reperfuse the body with oxygen. So therefore, I'm going to pass that red blood cell now through another valve here. And of course, that's going to be number 11. And number 11 is the valve between the left atrium and the left ventricle. That's going to be called the bicuspid valve. The bicuspid valve is going to have a function to prevent, it's also called, the mitral valve. The mitral valve, and the mitral valve is going to have a function to prevent backflow from the left ventricle to the left atrium during left ventricular systole. So again, when this valve here is pumping blood out, I don't want blood to pump back up. So I'm just going to make a real simple diagram showing those 4 valves, and you're going to see how very simple this really is. So that's your big picture. And now to just simplify it a little bit for you, I'm going to take a look at this 4-chambered heart rate here. And I'm going to not take all those little tiny things away and just show you 4 chambers. And I'm going to look at those valves. Remember, I've got a valve here. I've got a valve here. I've got another one here. And I have another one here. Let's look at each of those 4 valves. This valve here, let's say, is number 1. That's 2. That's 3. And that's 4. This first valve here, number 1, that's a valve between, remember, this is the RA and the RV. So that's the RAV, or the right atrioventricular valve. That's going to prevent backflow from the RV into the RA during RV systole. So when this pumps blood out, I don't want it to go back up. The second valve that we're looking at over here, that's my LAV, the left atrioventricular valve. Same thing. It's, of course, between the LA and the LV, but what it's doing, it's going to prevent backflow from the LV to the LA during LV systole. So that has those two valves have a systolic function. And then I've got these next valves here, which are going to be 3 and 4. Well, 3 is between the right ventricle and the pulmonary trunk or the pulmonary arteries. So 3 is going to be the pulmonic valve, or the pulmonary semilunar valve, and that's going to have a function to prevent backflow from the pulmonary trunk to the right ventricle during RV diastole. So when I'm pumping blood out, I don't want it to backflow into the right ventricles, because remember, we defined systole as pumping, diastole as relaxing. And finally, the fourth valve we've got here is going to be right there, and of course that number 4, that's going to be the aortic valve, or the aortic semilunar valve, and that's going to prevent backflow, but now it's going to be from the aorta into the left ventricle during LV diastole. As I'm pumping blood out into the body, I don't want it to backflow back into the chamber. Now, the last thing we want to know about the heart anatomy is looking at those chambers, because, you know, I've said the couple terms here. I've said bicuspid, I've said tricuspid. So if we look at a valve, and let's just simplify this here. If I look at this here and say, here's my heart, and here's a valve that's sitting here, and we'll call this for today, let's say here's your right atrium, and down here is my right ventricle. That's my RV. And therefore, we said that's the tricuspid valve, and a cusp is a point. So 1, 2, 3 pointed valve. That's why it's tricuspid. Each one of those cusps or points are going to actually have what are called a heartstring coming down. So those heartstrings, which is kind of a traditional term, are going to really be called the chordae tendineae. And then they are going to attach to specialized muscle called the papillary muscle. So those are what are going to control that valve. And then there's another type of specialized structure inside of the atria, and I'm just going to draw it as a squiggly line, and I'm going to call that pectinate muscle. And I'm going to say that the pectinate muscle maintains the form or structure of the heart. I always use the analogy of a soccer ball. If I took a soccer ball and inflated it, and then deflated it and re-inflated it, it would look like a soccer ball again. And the same with the heart. when I squeeze the heart to pump blood out, and then I fill it back up with blood in systole, it looks like a heart again. It maintains the form or structure of the heart. So those are your pectinate muscle that are found in those chambers, and I'm just showing you that in the right atrium and the right ventricle. There's also structures found inside the ventricles, and I'll put these here, and those are structures that maintain the form or structure of the heart wall, called trabeculae, which means tubules, carne, which means meat. So just like the pectinate muscle maintain the form or structure of the right atrium and the right ventricle, the trabeculae carne maintain the structure or form of the right ventricle and the left ventricle. If we just flip to the other side of the heart, just so you understand that same thing again, here's my structure of the heart. So here's now going to be the left atrium, and here's going to be my left ventricle. Same thing I'm going to have, except now I'm going to have a valve here, and because it's only got 2 points, that's the bicuspid valve, 1, 2. Coming off of that is going to be again the heartstrings or chordae tendineae. Chordae tendineae are going to be attached to papillary muscle. Left atrium is going to have some pectinate muscle to maintain the form or structure of the heart. The left ventricle is going to have trabeculae carne to maintain the form or structure of the heart. So now we know what the heart has as far as valves and how the valves operate. The other thing we want to understand about the heart is that if you think about the heart and you think of it as a fetus, you're actually using the placenta to oxygenate. I know that if I was to draw this very simple box heart rate here, and I said, tell me what the fetal heart is actually looks like compared to the after birth or adult heart, as I call it, I know that there's a septum between the chambers, and that's called, either up here it's called the interatrial septum, and that this is called the interventricular septum. Remember, inter means between, septum is a divider. This is the right atrium, right ventricle, left atrium, left ventricle. When I was a fetus, when you were a fetus, there was an opening. So when a fetus, there was a normal opening between the RA and the LA, which was called a foramen ovale, an oval depression or oval opening. That allowed mixing of blood between the chambers, because remember, my lungs were not functioning as a fetus, and therefore I was mixing my blood inside of my heart and using the placenta. So if that foramen ovale at birth is open, when I take my first breath of air, it starts to close. And it probably somewhere around 3 weeks, it should be completely closed, and it becomes what's called the fossa ovalis, or an oval depression. So if I looked at a cadaver's heart, I would see if they were normally closed up, it would be an oval depression in both atria. In some people, it doesn't close, and therefore, if it stays open, and that could be a small portion or a very large portion. If I looked at an echocardiogram, I could see some flowing between those chambers which shouldn't be there. That becomes what's called a patent foramen ovale, or a PFO, also called an atrial septal defect. Now, there's one other thing that you can see in this drawing that you want to understand, is you notice that there could be, so this was that opening that was here as a fetus that closed up normally at birth. But a child could be born with an opening between the left ventricle and the right ventricle. That is never, ever, ever normal. That's only pathologic. That would be called a VSD, or a ventricular septal defect, which is only pathology. Okay? Never normal. It's not going to close up on its own, and it's probably going to need surgery either immediately after birth or in a very short period of time, depending on the size of it, because remember, that's inside of my pumping chambers. Okay?
Let me ask you a quick question.
Sure.
Then. When someone listens to my heart, a physician say, what are those sounds that they're listening for?
All right. So remember when we were talking about the valves, and we said that we've really got 4 valves. So we've got 2 AV valves, 2 atrioventricular valves. And the 2 atrioventricular valves are going to form the first heart sound. And that's going to be the lub sound. And that's going to be commonly called the S1. So if you take a stethoscope and listen to your heart, that first heart sound you're hearing is the turbulent flow of the atrioventricular valves, the RAV and the LAV. The second heart sound is going to be, remember, there's 2 semilunar valves that we're going to have. So there's 2 atrioventricular, there's 2 semilunar valves. Remember, that's the aortic valve and the pulmonic valves. And those valves are going to form the second heart sound. And that second heart sound is going to be the dup sound. And that's going to be called the S2. So that's what you're actually listening to with the stethoscope as you're listening to the heart. And as you develop more and more, ability with it, you'll be able to listen for clicking sounds or defects in the valves.
Well, okay, so what about a heart attack? What's happening when I get a heart attack?
A heart attack. Let's think of really what's significant here. Well, when you studied muscle, you knew there was cardiac muscle is called the myocardium. Remember, the myocardium is striated involuntary muscle. I cannot tell my heart what to do. So therefore, in order for me to not be able to tell my heart what to do, I've got to kind of just think of what cardiac muscle looks like. So if I just drew something that's traditionally called a sarcomere in muscle, and just said this was taking a piece of skeletal muscle but turning into cardiac muscle, this, you may recall, is a Z line, a Z line, and a Z line. And between from one Z to the next Z was a sarcomere, which is the functional unit of skeletal muscle. But when I talk about cardiac muscle or myocardium, there's going to be a specialized structure that sits over the top between adjacent cells. So over the top of that Z line, if a muscle cell started here, so this is one cell, and this is a new cell that started over here. This is a second cell. And to join those 2 cells together, I have something called an ICD. And that's called an intercalated disc. And that electrically couples adjacent cardiac muscle, could be called the cells, could be called fibers, could be called myocytes. It's that structure there, along with the conduction system, that allows my heart to be autorhythmic. It's something you don't want to try, but if I took your heart out of your body, put it in a pan of some electrolytes, it actually could beat on its own because it can generate its own action potentials. So now when you say, well, what's really a heart attack? Well, a heart attack, of course, one more explanation than you know, is that the heart has to have a conduction system. And the conduction system of the heart relies on what are called conduction myofibrils. And a conduction myofibril equal a muscle cell that acts like a nerve cell. So if we look at the conduction system of the heart, all we have to do is draw that box one more time. And once we understand this, we can answer the question about a heart attack. Right here, we're going to put a 1. 1 is going to be the SA node equals the sinoatrial node, which is going to be called the pacemaker of the heart. That's why if you ever dissect a cadaver or you know someone's had a pacemaker implanted, it would be at the top of the right atrium. Remember, this is your RA, RV, LA, LV. I'm going to pass, because of means of those conduction myofibrils, an electrical potential that's going to pass through those ICDs until it gets to right here, and that's going to be number 2. And number 2 is going to be the AV node, or the atrial ventricular node. I'm going to then take that and just kind of split it up. So I'm just going to put a solid line there and call that 3. I'm going to say that 3 has got 2 names. Originally it was called the bundle of His. He was actually the man that discovered that histology of it. And now it's also called the AV bundle. And that's going to coordinate to split that off into 4 and 5. 4 is going to be called the RBB, or the right bundle branch. And 5 is the LBB, or the left bundle branch. Now I'm going to take that electrical activity and literally light up the heart so it can fire. And those kind of lightning bolts that I'm seeing flashing through the heart are 6. And that's going to be the Purkinje system. And that basically is the conduction system of the heart. Now your question was, well then, what would a heart attack really be? So now, to make it very kind of straightforward, think about the word EKG. Everyone's heard of an EKG. Electrocardiogram we do, or an ECG. The EKG actually comes from the German form cardio. This is the English cardio, C-A-R-D-I-O. Electrocardiogram is really looking at the gross electrical activity in the heart. And so therefore, if we look at each chamber, we know that the pumping chambers would have to have more muscle mass than the collecting chambers. So if we look at the thickness of the myocardium, it's going to be the left ventricle is thicker than the right ventricle, is thicker than the left atrium, which is thicker than the right atrium. So therefore, when we do an EKG and I put leads on you, I'm going to say that this is a normal EKG. A normal EKG, we're going to start with a flat line, kind of a bump elevation up. I'm going to come down, up, and over. That's kind of a textbook EKG. We're going to label that as a P, a Q, an R, an S, and a T. The P is going to signify atrial depolarization. So that's the upper chambers of the heart depolarizing. QRS is going to be called the QRS complex. And that's going to be ventricular depolarization. And then finally, the T wave is going to be ventricular repolarization. And now you should ask yourself, well, then where do the atria repolarize? Well, because the atria have such little muscle mass.
Let me stop you right there. You hit that button on the, there you go.
Because I have such little muscle mass in the atria, it's actually hidden right inside of here. So my QRS complex has a ventricular depolarization and a hidden atrial repolarization. Okay, so that's what I would say a normal EKG. Now before I show you the heart attack, let me just make this simple so you understand what that means by depolarization and repolarization. Real simple analogy. You had a magnet someone gave you. They gave you 2 bar magnets. And you had 2 of them. And you said, wow, if I take these 2 magnets and I try and touch them together, so I'm taking these magnets together, I notice if I go like this, they attract. And if I flip this one around, they repel. So now they came together here. And when I flipped them, they repel one another. So that meant that there's a charge on either end of that magnet. So if this is a negative, and a positive, these 2 negatives what are they gonna do? Well, they're gonna repel. But if I flip this around, so this is my 1 bar magnet, which is the plus here and negative here, and flip this one so that the negative is the positive is here and the negative is here, these 2 are going to come together and they're going to not repel but come together but join one another, attract. That's going to repel, that's going to attract. So that shows that there's a polarity inside of a bar magnet. Now, when you say depolarize and repolarize, it's nothing more than just like your car battery. So kind of think, here's a car battery. Car battery's got 12 volts. And therefore, in effect, if you were to really look at a battery, it's got double cases. It's got a case on the inside, on the outside, and it's got a pole on either side. Let's say this is the positive and this is the negative. And there's hydrochloric acid sitting in that battery, and that acid that's in the battery, and let's just say that it's polarized. So that means it's going to have all plus charges on the outside and negative charges on the inside. That's polarized. But then I'm going to have to, as I discharge that battery, I'm going to depolarize. So when I start depolarizing, now it's going to, if I look at that same battery down here, I'm going to see that some of those charges have moved around. Now I'm going to have some positives and negatives on the outside, and just the opposite. So this is now going to have another set of, this is going to be now positive, negative, negative, and then on the outside, negative, positive, positive. That's depolarized. And so therefore, the heart, just like the car battery, as you charge the battery, it's going to have to go back to where it started, and that's going to be repolarized. It's as simple as that. It's just the electrolytes moving around. Good example, you went to cut the grass on a really hot day. What happened? Well, someone kept on giving you bottles of water. Well, the bottle of water sounded great. The problem is when you drink water, it hemodilutes. So I lost all those electrolytes in sweating, my sodium, chloride, and potassium. And now when you added more water, the hemodilution of the water without any electrolytes caused me to even have a lower electrolyte level. And therefore, that's why I had a heart attack by cutting grass on a hot day. That's how you have to think about the heart. So finally, we can finally get to answer that question, is what happens when I have a heart attack? Well, what happens when I have a heart attack is we're just going to say that this is to make it very simple for today, and so you understand what it really means, is that right here I'm trying to send this electrical impulse from here. So let's just say that's the sinoatrial node, and let's just say this is the AV or atrioventricular node. And if this was a normal person, I would just have conduction myofibrils sending down from here to here. Problem is that let's say that I had a heart attack. So one of my coronary vessels occluded, and therefore I was not getting oxygen to the myocardium. So therefore, this, I'm going to draw what I would call a bullseye right inside of here. And I know that what happened when I initially had my heart attack, this electrical impulse, instead of going directly from SA to AV, it had to bypass it. And so it got to here, and when I had to go around it, and then end up over here. And of course, when I did that, that showed that I had a heart attack right here. So that darkened line is called the zone of infarction. That means that's dead tissue. It can never depolarize or repolarize. It can never function again. So therefore, I had to make a detour around it. And of course, a detour, if you kind of think what a detour does on a car, when you're driving, it takes time. And therefore, the same here. If my heart is beating at 72 beats per minute, is my heart rate, that means that I have a cardiac cycle. Remember, a cardiac cycle is from the beginning of the P wave to the end of the T wave. So if my heart is beating at 72 beats a minute, every 0.8 of a second, I'm going to have a cardiac cycle. If I have a detour, this could maybe be 2 seconds. Problem is now, this chamber is already refilling with blood, and it hasn't pumped the blood out yet, hasn't released it, and therefore I'm going to start having backflow pressure. And so therefore that's when I'm going to see an arrhythmia. And so therefore now when I look at that EKG, I'm going to see something that kind of looks like this. I'm going to have a straight line. So remember, that straight line is called the isoelectric point. Remember, the isoelectric point is neither a negative nor positive deflection. And another name for that would be asystole or flat line. So that term flat line means that all I'm seeing is a flat line. It's not going to positive nor negative. Then I'm going to have a P wave. So here's my P wave. Looks pretty normal. But now when I get over to here, I'm going to probably have something that's going to have a Q, and then it's going to slope down kind of like this and like this. And so now what I see is that I've got a what's called a STEMI. And a STEMI is a classic word for a heart attack, which is a elevated ST segment. And that's the slope that I'm seeing right here. And then since that's the T wave plus a inverted T wave. And therefore, that is your classic heart attack or STEMI. Elevated ST segment, inverted T wave. And of course, when you get to the hospital and they do that EKG, they may say, well, you know, he had a very mild heart attack. That means that only this area was infarcted. And now they'd say, well, we got to watch him closely for the next 48 to 72 hours because things could change. Because that, if I don't somehow reinstitute the blood flow to the heart, it's going to go to this second area, which is called the zone of injury. And the third thing out here is the zone of ischemia. Ischemia means compromised blood supply. So my goal is, when you have a heart attack, is to prevent this circle from going out to the zone of injury or the zone of ischemia. How do I treat that? Well, just think of the treatments you could do. One, you could chew 325 milligrams of aspirin, which is ASA or acetylsalicylic acid. That will prevent platelet clumping. Naturally, you could give oxygen, so administer oxygen. The next thing you do when you get to the hospital, you go to the cath lab, do a cardiac cath. And now your option is that you can either put in a stent, you could take some kind of a clot buster, the tissue plasminogen activator, to try and break up the clotting of those platelets that may have occurred in one of those coronary arteries. Or you could do a cabbage procedure, which is a bypass or a coronary artery bypass graft. Any other questions that we have?
One last one.
Sure.
So I had a buddy of mine just recently got a heart valve replaced.
Okay.
And when he went to the dentist, they gave him antibiotics to get his teeth clean. Why?
All right. Well, I guess that's a fairly simple question to answer. And the reason you want to give prophylactic antibiotics, and let's just tell you why you do that. Because remember when I talked about these valves here, and remember there's really 4 valves we're looking at in the heart. And of course, the 2 real significant ones are these valves between the right atrium, right ventricle, left atrium, left ventricle. And oftentimes people have to have their mitral valve replaced because they may have had mitral valve regurgitation. So let's say that your friend had a mitral valve replacement. Anytime that you have any type of procedure done, you're going to have a roughened area where they either put the new valve in. And because of that, bacteria or any foreign substance tend to accumulate anywhere where there's a roughened flow. And so therefore, when I clean someone's teeth, remember the vessels in my mouth go directly into my systemic circuit. So that bacteria, when I see that bleeding, actually can enter my systemic circuit. And then when they get into the heart, they're going to find some place that they can vegetate. So they may vegetate and grow right alongside of here. and therefore now you're by the valve or somewhere in the endocardium, because I had to literally cut through that endocardium to put in the synthetic valve, and therefore I'm going to develop an endocarditis. So anyone that has any kind of implant, whether it's a hip implant, knee prosthesis, heart valve in your heart, you're always probably safe to have a prophylactic antibiotic to prevent an infection of that valve or infection of that implant. Now I think that basically covers the heart. So you always want to think of, always be able to trace a drop of blood. If you can take a drop of blood, and when you look at any kind of a box heart, as I tend to do, you always want to ask yourself, where did that blood come from? Where is that blood going to? Is that blood increased O2 blood arterial or decreased O2 venous? Is it going to pass through a valve? If so, what valve? When it leaves that valve, what vessel? If it leaves that vessel, where is that vessel going to? And then think about any type of specialized structures in the heart. Remember, we had papillary muscle, we had pectinate muscle. Those two muscles had different significances. Remember, pectinate muscle maintained the former structure of the atria. Papillary muscle connected to the chordae tendae of the heartstrings. The trabeculae carneae maintain the former structure of the heart, and always think that trabeculae carneae and pectinate muscle are really analogous structures. Pectinate muscle being in the atrial chambers and trabeculae carneae being in the pumping chambers. And that really concludes my lecture around the heart. And thank you, and have a great day.